Welcome to a short presentation on how to implement the updated International Expert Consensus Guidelines on Physiological Interpretation of CTG, which was published in October 2024 in our daily clinical practice. So the part one of the presentation is going to deal with understanding the principles. So before I start, I would like to thank the International Expert Panel. We incorporated both chorioamnionitis and hypoxic stress in the current update. This is an update from the 2018 Consensus Guidelines. And we had a 15-member editorial board and overall more than 50 international experts on physiological interpretation of CTG from 20 countries and from all 6 continents except Antarctica. So it was a large consensus group with experts who have been using physiological interpretation of CTG in their daily practice. So before I start, I would like to thank both the members of the editorial board, and they were selected based on their own expertise and showing positive outcomes after implementing physiological interpretation of CTG. And I'm also very grateful for our international expert consensus panel from over 20 countries who contributed immensely for the development of these guidelines. So the 3 parts of the presentation, this is going to be understanding the principles. Then we are going to talk about case examples, how we are going to apply the various tools that are recommended by the guidelines. And the 3rd part of the presentation is going to be, why should we change now? Why should we urgently change and move to physiological interpretation of CTG? So let's now look at the basic principles of implementation of physiological interpretation of CTG. So if you are talking about fetal well-being in labor, we need to exclude pre-existing causes of fetal compromise. So in 2018 guideline, we introduced the concept of, is this fetus fit to undertake the journey of labor, by having a fetal monitoring checklist at the beginning. Then if there is onset of hypoxic stress, it's important to recognize it in a timely manner, and that's why we have different types of hypoxia and a combination of or sequence of features, and to assess the fetal compensatory response to stress by asking the question, how is this fetus? And also we have a gamut of other conditions which are non-hypoxic, inflammatory for example, and we need to make sure that we recognize them. So that right management has to be provided at the right time. And it is not only about a piece of CTG trace, it is also about the wider clinical context that includes the progressive labor and other risk factors like meconium, staining of amniotic fluid. So we know that human labor is a journey of hypoxic stress, because once the contraction starts, what happens is all the spiral arterioles and branches of the uterine arteries which supply the placental bed, they get intermittently compressed. Not only that, the umbilical cord also gets squeezed depending on where the cord is or depending on the amount of amniotic fluid around. So a human fetus is exposed to transient episodes of hypoxemia. It is just like you and I dipping under the swimming pool for about half a minute, 1 minute. We are unable to take in oxygen, we are unable to give out carbon dioxide when we are underwater. In the same time, in the same manner, when an umbilical cord is intermittently squeezed or placental blood supply is cut off with the contractions, a human fetus experiences intermittent hypoxemias episodes. And unfortunately, unlike running a marathon, in human labor, the hypoxic stress is never constant. It is continuously increasing, because in latent phase of labor, you might have 1 or 2 contractions lasting for 20 seconds. Then when the active phase of labor commences, you might have 2 to 3 contractions lasting for about 40 seconds. But towards the end of first stage of labor, you may have 3 to 4 contractions lasting for approximately a minute. And second stage of labor, in addition to these contractions, there is effect of active maternal pushing as well. So there is going to be progressive worsening of hypoxia, but most human fetuses are able to compensate because they have a buffering system, they have got reflex responses, and they have a good placental reserve, approximately 50%. However, there are some fetuses who may not be able to compensate. For example, fetal growth restriction, chorioamnionitis, and they may go into decompensation. And it is our role as midwives, nurses, doctors working in labor wards around the world to recognize and differentiate the features of compensation from decompensation. So when we look at intrauterine fetal stress, it may be hypoxic, and that can be developing over a number of hours, what we call gradually evolving hypoxia. Or it could be quite rapidly evolving. For example, if you have used too much of oxytocin or prostaglandins, or when the mother is actively pushing in second stage of labor, and the rapidly evolving hypoxia can come within 30 to 60 or 90 minutes. Or there can be an acute profound hypoxic insult, umbilical cord prolapse, uterine rupture, where oxygen delivery is immediately interrupted and immediate action has to be taken, and this has to be recognized in about 3 minutes so that we can have timely action to improve outcomes or correct the problem. So apart from the hypoxic stress, a human fetus also is exposed to inflammatory stress. It could be maternal source, for example, urinary tract infection or respiratory infection, gastroenteritis, but that is a small part of the inflammatory damage. The larger group of damage from inflammation happens from the ascending organisms like E. coli, GBS, ureaplasma. They go from the vagina up through the cervical canal and infect the fetus. And that might take, depending on the incubation period and the load of the bacteria and the multiplication and the host defense mechanisms, it might take a number of hours to develop. Then the fetus also may be exposed to non-hypoxic causes, just like postpartum hemorrhage. If there's a sudden fetal-maternal hemorrhage, either into the placenta, or there's a ruptured vasa previa or placental abruption, where the baby might lose a significant amount of blood loss. Or it could be cardiac or stroke. So all those require urgent action. And this is why interpretation of fetal heart changes should be accurate and appropriate. We cannot use normal suspicious pathological, because when you say suspicious, if you ask honestly an obstetrician or midwife who calls a CTG suspicious, if they have probity and honesty, they would say, we don't know. That's why we are suspecting something. Whereas we cannot allow that to happen when you do physiological interpretation of CTG. We have a responsibility. Just like cardiologists looking at an ECG, they have a responsibility to make a diagnosis. As obstetricians, midwives, and nurses working across the labor wards, we also have a responsibility and a duty to get it right. And in the current guideline, we have introduced the concept of relative uteroplacental insufficiency, or RUPI, which is a subclinical uteroplacental insufficiency, which sits in between a gradually evolving hypoxia and a rapidly evolving hypoxia. And we'll be looking at it very soon. So before I start, let's address some of the controversial aspects of the consensus. Because remember, this is a consensus guidelines. We had 15 members of editorial board, and we are all independent professionals, and we have over 50 members in the International Consensus panel, and therefore it is obvious that there will be difference in opinions and we need to reach a consensus. And therefore the consensus that we have reached may be controversial to someone else. So let me address those consensus first. One of the first issues is fetal heart rate decelerations. So if you look at our heart, it is pumping blood because if you have a good circulation to the cardiac chambers and you have good ventricular filling, and when the ventricles contract, as the oxygenated blood leaves the left ventricle, it goes from the root of the aorta through the coronary arteries, and they come to supply the heart again. So the first organ that gets the fresh oxygenated blood is the myocardium itself, because myocardium has been prioritized. If the myocardium fails, it's pointless having a big brain or other organs. And then through the carotid artery, because you have a good cardiac filling with oxygenated blood, there's a good cardiac output and a stroke volume, of course, and therefore the brain gets good oxygenation. So if you look at the demand-supply equation, the myocardial oxygen supply is always kept more than the demand. And when we are in this situation, all of us are in this situation, I hope, at the moment, and that puts us in an aerobic metabolism because oxygen delivery is more than the demand, and our myocardium is going to be in the positive energy balance, and we are okay. But imagine if the situation gets other way around, where the cardiac demand increases more than the supply. So this can happen in adults when we do heavy exercise, for example, or when we are exposed to sepsis, when the metabolic demand of the myocardium increases. Or it could be bronchial asthma, where the demand may not go up, but the supply has reduced. Or pneumonia, COVID pneumonia, for example, where we are unable to oxygenate our heart. In those cases, the demand of the myocardium is greater than the supply. And fetuses also experience similar situation, because when the umbilical cord gets squeezed or placental blood supply gets cut off, their oxygen supply coming via the umbilical cord is reduced, and therefore the cardiac demand outstrips the supply. So imagine what would happen in that situation. So immediately the heart will not get enough oxygen. If the heart doesn't get enough oxygen, you are going to have reduced diastolic and systolic function, cardiac filling, and the force of contraction and cardiac output is not going to happen when there is myocardial hypoxia. And that, if it is not corrected, the myocardium can go from aerobic to anaerobic metabolism, and we get into a negative myocardial energy balance, and that's the time we start producing lactate in the myocardium. So similar to in the gym, when you run faster, you suddenly get pain in your calf due to anaerobic metabolism of your calf muscles, and you get pain and cramps, and you slow down and stop. In the same way, once you put lactate in the heart muscle, which is a muscle like a calf muscle, myocardium is similar, and once there's lactate, this rate of functioning of the myocardium gets slower and slower and slower, and therefore your baseline heart rate tends to fall down, and finally you might have a step ladder pattern to death, culminating in a terminal bradycardia. So that is what happens in the absence of oxygen. So what do we do as adults? Each time when we are faced with a demand-supply problem, because we want to maintain the supply more than the demand, but if by any reason, any chance, the supply is less than the demand, we use our heart-lung mechanism to increase our rate and depth of respiration. And that's what we do when we run, when we jog, we breathe faster. When we have sepsis, we get more oxygen. A woman with postpartum hemorrhage is breathing faster. And that's because we try our best to increase the supply because we are exposed to 20% oxygen in air. And that helps us to deal with the myocardial energy problem. So we keep maintaining aerobic metabolism in the myocardium by increasing our supply of oxygen, by increasing the rate and depth of respiration. But if you're a fetus, once contractions start and they are squeezing your placental blood supply as well as umbilical cord, you are unable to increase your rate and depth of respiration simply because you are immersed in a pool of amniotic fluid. And therefore, we need to then find different ways of dealing with this. And one of the ways we deal with it as fetuses is, since we cannot increase the supply of oxygen, the only way we could deal with a reduced supply problem is to reduce the demand to maintain the equation. So as long as we maintain the demand-supply equation, there is no anaerobic metabolism and there is no development of lactic acid. So decelerations, we have defined the same in FIGO guidelines in 2015, 2018 Physiological guidelines and 2024 Physiological guidelines, that these are reflex cardioprotective responses to reduce the myocardial workload, to protect the myocardium. So if you go back to our historical confusion, we fail to realize the physiology, that these are protective responses. So most guidelines, they call them various names and panicked and did interventions. It's like fetal blood sampling, scratching the baby's head, fetal scalp stimulation, or cesarean section, or vacuum or forceps, because of lack of understanding of what these meant. Whatever that is physiological was considered as pathological. The good example I can give you is that in the gym, when you are breathing faster, imagine a retired obstetrician like Edwin Chandraharan comes and gives you oxygen, because they don't understand that the increased respiratory rate and depth of respiration in the gym is your physiological compensation. In the same way, fetal heart rate intermittent decelerations, they are cardioprotective reflexes. They are fetal counterpart of adult respiratory rate. So what did we do? We invented morphological identification, tried to find how ugly they are. What is the depth of the deceleration? What is the duration of the deceleration? And how long are these decelerations going on for? And we created various crazy classification systems, including, without realizing that if you have a coupling of contractions, you will have a deceleration going down and then going up again. We call them concerning features. There's nothing concerning about it. If you hold your nose and go underwater and then come back, you will breathe very hard to get more oxygen. The longer you go down, the more your breathing will be. And that is your physiological response in the swimming pool. So here we didn't understand it, so some started calling them names, early, variable, late. Then they couldn't understand the variables like Wharton's jelly, the amniotic fluid volume, nothing was done. Lack of understanding led to panic, and they didn't understand why are these decelerations so different. So due to confusion, we had to now bifurcate variable decelerations into typical, atypical. And then some said, ooh, that looks a bit complicated, make them complicated. Add an N uncomplicated. Make it reassuring. Add a non-reassuring. You can see the amount of confusion we had. And because of lack of knowledge and classification of physiological responses as pathological, we had disastrous outcomes. Lots of women had unnecessary cesarean sections because of the high false positive rate. And therefore, the international guidelines, consensus guidelines, we have clearly stated that the panel recognizes the historic obstetric practice of classifying the decelerations into various morphological types. And they have no correlation with perinatal outcomes. Therefore, we said we strongly recommend that clinicians should look in between the decelerations to look for stability of the baseline and reassuring variability. And that is based on research evidence. And we were able to show about 5 years ago that it doesn't matter how the deceleration looks like, variable, late, it doesn't matter. As long as the baseline and the variability were normal, none of the babies had acidosis. In the same way, we looked at catecholamine response. So even if the baby had or fetus had repetitive decelerations and has increased the heart rate, but as long as the fetal heart rate variability remained normal and the baseline was stable, none of the babies had acidosis. It is only when the baseline variability was reduced, approximately 30% of these fetuses had acidosis. So we made a statement in the guideline regarding the morphology of fetal heart rate decelerations. The international expert consensus group recommends that with evolving understanding and confidence in physiological interpretation of CTGs, clinicians should move away from identifying the morphology of the decelerations, but assess the intervening baseline for the stability, reassuring variability, cycling to determine fetal well-being. It is because of the simple fact that if you ask yourself, you had started a journey into physiological interpretation of CTG. And all of us who are listening, we are at different stages in that journey. Most of us, if you look back and open the skeletons in the cupboard, we were doing normal, suspicious, pathological. Some of us were cutting the skin to look for acid in the brain. How crazy was that? Some of us were calling the CTG suspicious and giving fluids to the wrong patient, the mother. We did all that. So some of us may have been advanced in the journey of physiological interpretation of CTG, but let's not forget some of our friends and colleagues are starting their journey. And therefore, we cannot have one guideline fitting all. So personally, if you ask me, I would have said no decelerations. Don't worry about it. Just look for baseline and variability. In fact, I would have said that in 2018 when we produced the first guideline. But we had to accept that we are going to have a group of colleagues who are starting this journey. And for them, they have been brainwashed by various guidelines that decelerations were bad. And they have been trained to look at decelerations. And this is the reason why we haven't taken the deceleration as some of us would have wanted to do. So the second thing was changing the terminology of decelerations. For the last 18 years, ever since I started my own journey on physiological interpretation of CTG, in all my master classes and my textbooks, we have talked about baroreceptors and chemoreceptor deceleration. Very simple. Anything that is quick is due to blood pressure changes in the fetus, so baroreceptor decelerations. Anything that is slow to recover, that is accumulation of carbon dioxide and acid and low oxygen tension, and therefore chemoreceptor deceleration. But over the last 5 years, there have been some animal study groups who are doing some sheep experiment. So they are taking the sheep, and the mom sheep is anesthetized. The baby sheep or the fetal lamb is instrumented, and they use some silicone occluders to squeeze the umbilical cord alone. And they said, well, mostly it is chemoreceptor deceleration. And this argument has been going on in the academic world. And what the research groups fail to understand, that human labor doesn't start with umbilical cord compression. The main problem is in the placenta. And when the placenta gets compressed, there are studies have shown about 30 years ago that there is a bolus of oxygen going to the fetus, a volume of from the placental venous sinuses. In fact, the fetal oxygen saturation increases before the contraction or at the beginning of the contraction. So if you have a bolus of blood going into the fetus, increasing the blood volume and stroke volume, you may have increase in hypertension, stimulating the baroreceptors. So just by isolatedly taking animals and squeezing the umbilical cord without having this mechanism first, we cannot conclude that there is no baroreceptor stimulation. But when we looked at it, we didn't want to start an argument, because we are all doing physiological interpretation of CTG to improve outcomes for women and babies. That is our primary goal. And that means we must lose some battles with some who keep on arguing about the mechanism of decelerations. Because if you are a frontline midwife, doctor or nurse looking after women and babies, you don't worry about the mechanism. You are trying to identify the cause, to correct the cause. And this is the reason why we have changed the terminology so that no one attacks physiological interpretation of CTG saying they are wrong because they are using baroreceptors, and some animal studies have shown baroreceptors are not involved. So to go away from these arguments which are unproductive, we have introduced, instead of baroreceptor, quickly is quick. That's what it means, due to cord compression. Whereas anything that comes slowly is tardy deceleration, is slow. The reason we need to know this is that if you have a quick lead deceleration, that means it's a cord problem. You can modify it by changing position, etc. If you are having a tardy deceleration, it's a placental problem. Unless we have given too much of oxytocin, it is very difficult to change it because placenta is diseased. And therefore, we need to make a clinical decision based on the parity, progress of labor, presence of meconium, etc. So you can see that is the controversy for some because of the change of terminology, but we had to do it to protect women and babies by stopping these illogical arguments in trying to translate and transpose the data from animal studies. So we all knew for a long time, when those of us who did physiological interpretation of CTG, it has certain principles. Exclude pre-existing hypoxia and pre-existing compromise by using a checklist. Then each time during intrapartum period, we need to understand the fetal physiological responses to determine the type of hypoxia and the fetal response to stress by asking the question, how is the fetus? Then we need to look at the wider clinical context so that we individualize care. And now in this updated guideline, we have also added chorioamnionitis, which was not there in the first guideline in 2018, only because we didn't want to include something without scientific evidence to back it up. And now we will see we have got scientific evidence to back it up. And then you have non-hypoxic causes. So let's go through this guideline. It's very simple. So if it starts with no hypoxia, so everyone understands or would agree that this is no hypoxia because it says the baseline is appropriate for the gestational age. So if a fetus at 40 weeks comes to you with a baseline of 150, the rest may look normal, but that baseline is not appropriate gestational age. So baby might be having chorioamnionitis. Then you should have normal fetal heart rate variability and presence of cycling. So you can see here there's an alternative epochs of normal variability and reduced variability. This is REM sleep, rapid eye movement sleep, and non-rapid eye movement sleep. So they have to have a variability reducing every 50 minutes or so. So this is a normal CTG, and there's no repetitive deceleration. So you could have a CTG like this, where you can see the baseline is appropriate for gestational age, it's 38 weeker. There is normal variability and cycling. You can see variability here is normal, here is reduced, there is cycling, and you have decelerations, but they are not repetitive. And therefore, these fetuses would fall under no hypoxia. I am saying hypoxia and not hypoxemia. Please see that the guideline says hypoxia, so let's not get confused. And let's also not get confused illogically by some guidelines have called repetitive deceleration is 50% of the contraction for 30 minutes. There's no evidence at all because there are lots of variables. Fetal reserve is a variable. The intensity of the contractions is the variable. Duration of the contraction is variable. Placental function is a variable. So you cannot say 50% of the contraction for 30 minutes. After that, somehow the fetus becomes pathological, because a growth restricted fetus will decompensate much earlier. But some still have that mindset. So we should go away from the mindset as long as you can see there's no hypoxia. Decelerations which are quick will have hypoxemia, just like when you are going underwater in the swimming pool. Transient hypoxemia. As long as they are recovering and the fetus is maintaining a stable baseline and reassuring variability and cycling, this is no hypoxia. Hypoxemia is different from hypoxia, because by hypoxemia we mean reduced oxygen saturation in the arterial blood. That's what it means when there's a cord compression, when there's placental blood vessels are squeezed with the contraction. What is happening to the fetus is there's a transient reduction in oxygen content of the arterial blood. Whereas if that gets translated to the tissues, where the tissues are having less oxygen, and that is what is called hypoxia. And what would we do immediately in that situation? You and I have to pump more blood to the tissues to prevent them from becoming hypoxia. And they are hypoxic. And therefore, our baseline heart rate will increase to pump more blood, especially as a fetus. When they operate at the maximum Frank-Starling's law of the heart, they cannot increase the cardiac output by increasing the stroke volume. The only way they can increase the cardiac output by increasing the heart rate. So they increase the heart rate. And that's why when you say no hypoxia, the baseline shouldn't go up. It's still no hypoxia. Finally, if there is hypoxia to the central organs, namely brain, heart, and the adrenal, we call it birth asphyxia. And that is very late. And that is the one that is associated with hypoxic ischemic encephalopathy, long-term neurological poor outcomes, as well as when the heart also is a central organ, when there's asphyxia in the heart, you will have myocardial decompensation and terminal bradycardia. So that is your no hypoxia. Now let's go to chronic hypoxia. Chronic hypoxia at 41 weeks, if you get a CTG like this, you would expect the baseline to be less than 140. So here the baseline is higher than expected. So you can see what the guideline tells you. The higher than expected baseline for gestational age, reduced variability and absence of cycling, absence of accelerations, and these shallow decelerations. That's because the fetus has lost its compensatory responses. It cannot mount a very big deceleration. CNS is depressed. So the guideline tells you if you have chronic hypoxia, you avoid further stress and expedite delivery. So in the guideline tool, in part 2 of the presentation, we'll be going through these tools and how to apply these tools in real life. But this is just to give you a flavor in part 1, so you can see if you have used the tool which is in the guideline, the fetal monitoring checklist, to ask, is this fetus fit for labor? You would have said the baseline is not approved for gestational age, there is no normal variability and cycling, no accelerations, there are shallow decelerations, and therefore your diagnosis is chronic hypoxia. One of the other things we included in this guideline is relative uteroplacental insufficiency of labor. So the chronic hypoxia is easy to understand. At the beginning of labor, the fetus is showing you 3 typical features: higher than expected baseline, reduced variability and absence of cycling in one, and shallow decelerations. But imagine a fetus comes to you with subclinical placental insufficiency, because the Doppler changes will only be seen on ultrasound scan and Doppler if more than 50% of the placenta is approximately damaged. What if the fetus comes to you with a 20-25% loss of placental function? You put a CTG at the beginning of labor, that fetus is going to be absolutely fine. Whereas in gradually evolving hypoxia, the hypoxic changes happens very, very late. Whereas in relative uteroplacental insufficiency, because of this fetus having a subclinical problem, the moment the placenta or the uterus contracts, or if there is increased fetal demand, for example, diabetes or chorioamnionitis, then as soon as the contraction commences, the fetus is going to show you various changes, including tardy decelerations or zigzag patterns. So this is why we included this special category called RUPL, relative uteroplacental insufficiency of labor, and that's because these fetuses are not having chronic hypoxia, they are not having gradually evolving hypoxia. They are in a situation where it's like me having a partially occluded coronary arteries. When you look at me at rest, I am okay, I am talking to you, I have no problem. But the moment you put me on the treadmill, within the first 5 minutes, I am just panting. Whereas if I am having gradually evolving hypoxia, I have no coronary artery disease, and therefore I am going to the gym, I am going to start exercising. Only after 30, 40, 50 minutes of exercise, I am going to show those physiological changes. Whereas if my coronary artery is partially blocked, if it is totally blocked, you will see me at rest having chest pain and increased breathlessness. But if it is partially blocked, I am going to be fine at rest. I am going to be fine with slow walking. The moment I try to do something that I shouldn't do, I am going to show you acute changes. And that's what these RUPL babies show: autonomic instability, zigzag pattern, or you can have fetal heart rate overshoots. Then we come to gradually evolving hypoxia. Let's look at the compensated gradually evolving hypoxia. So the guideline tells you there should be a rise in the baseline, because we said this, we are now talking about hypoxia, not hypoxemia. In hypoxemia, you have no reason to release catecholamines. They are transient episodes. Whereas when the tissues are now getting less oxygen, you need to increase the cardiac output to supply those tissues. And that's why it starts, we have said, rise in the baseline with normal variability and stable baseline, because it's a compensated. So it's in the gym, you're breathing faster, you're tachycardic, you're not feeling faintish, you're not having a chest pain, because your central organs are still well oxygenated. So here you have a stable baseline. Myocardium has good oxygenation, and the brain has reassuring variability, but you have increased your catecholamines. So you can see here the fetus came with a baseline of about 130, and with repetitive decelerations the baseline has gone up. But if you look in between the decelerations, you see normal variability and stable baseline. And you can see some of them can be quickly, some of them can be tardy. It depends on where the problem is. Is it the cord or the placenta? But the main thing is they are compensated gradually evolving hypoxia because the fetal heart rate has increased at least 10% rise due to catecholamines, but in between you have got a stable baseline and reassuring variability. Now those who have got the old mindset where they are panicking about morphology of decelerations, they would say, what about this? But the principles are the same. However ugly the deceleration looks, as long as the baseline heart rate hasn't increased, it is still hypoxemia. So it is not classified under gradually evolving hypoxia. But as I said, it's a journey for some, and that's the reason, if you see the second part of this, we have said if the inter-deceleration interval is greater than the time spent during the deceleration, then still it's a compensated state. So please don't panic. These are, unless the baseline heart rate goes up, we cannot consider these fetuses as having hypoxia. They are having episodes of hypoxemia. So far, they haven't needed to increase the baseline to perfuse the tissues. So here you can see the time spent in the baseline is much, much longer than the time spent in the deceleration. And however ugly it looks, the principles are the same. Look in between. And some would panic because 50% of the contraction for 30 minutes, that's an old currency. And that currency had no scientific evidence to back it up. Once you understand physiology, you look in between the deceleration, look whether baseline has gone up. If the baseline has gone up, look for stability of the baseline and variability. So that is going to be your gradually evolving hypoxia. And that if the time spent in the baseline is longer than time spent in the deceleration, the guideline gives you guidance as to how we should manage. It's all about reducing the stress when the baseline has gone up. Now you can see a situation here. There have been repetitive decelerations. The baseline has increased, and now there is onset of reduced variability. And this is what we call a decompensated gradually evolving hypoxia. Because once the baseline variability gets reduced, that means there's CNS depression. So the amount of blood that is going through the carotid artery is no longer able to meet the metabolic demands of the neurons. And there is increased risk of acidosis. And we have said they may have reduced variability, or you can see here the contractions are so frequent. So in that situation, autonomic instability can increase the variability too. So we looked at gradually evolving hypoxia, which is compensated, where you'll have repetitive deceleration followed by increase in the heart rate, but normal variability and stable baseline. And decompensation, when there are variability changes. So please remember, it's variability changes, either reduced or increased variability. And when you look at a CTG trace like this, if you use the old currency, you will panic because they are ugly, they are repetitive. But once you understand fetal physiology, you'll take a deep breath because you understand it. In my master classes, I introduced about 18 years ago using 50 pence coin. And when I used to go to European master classes, I used to use €2 coin, the largest coin, to cover these decelerations and look in between the deceleration. And this fetus is telling you, yes, I am stressed. I have got transient hypoxemia because I haven't still increased the baseline yet. And this fetus is telling you these are quickly decelerations. And therefore, you have got a cord problem, which is often correctable. So you can see stable baseline reassuring variability. So this tool we'll be discussing in part 2. But if we have used this intrapartum fetal assessment tool recommended by the guideline, you would have put an initial baseline and current baseline. And because this baseline hasn't gone up, you would say, no, there's no 10% rise in the baseline. So it's still episodes of hypoxemia and there is no hypoxia acidosis. And then you can see it'll be a gradually evolving hypoxia. If you look in between the decelerations, stable baseline reassuring variability, and therefore the central organs are well oxygenated. And if you look at these strays, look at the variability there. So repetitive deceleration, rise in the baseline, but variability is reduced. So here you would put on the other side because central organs are not well oxygenated. So again, you see here, decelerations are not that big. But look, the baseline has gone up and the variability is reduced. So this is a decompensated, gradually evolving hypoxia. And the guideline tells you what to do. And it is not to rush and deliver, it is always to improve oxygenation. So we looked at no hypoxia, we looked at chronic hypoxia, we looked at RUPI, we looked at gradually evolving hypoxia. The next type of hypoxia is the easiest to recognize because the time spent in the baseline is less than time spent in the deceleration. And we know that as a swimmer, if you spend less time in the top of the swimming pool and keep going down, you're going to have hypoxia acidosis very soon. You're going to struggle. In the same way, if the fetus has less time at the baseline to exchange gases, get fresh oxygen and give carbon dioxide, and then the decelerations are longer, you are going to have subacute hypoxia. And often it is associated with zigzag pattern because that's autonomic instability. And you can see this is a subacute hypoxia. Less time in the baseline, more time decelerating. So the guideline tells you what to do in the first stage of labor. If you get subacute hypoxia in the first stage of labor, either it is due to too much of oxytocin, too much of prostaglandin, or tight cord around the neck, causing intense or severe oligohydramnios with cord compression. Otherwise, it's a problem usually in the second stage of labor, often with active maternal pushing. Then we come to the acute hypoxia. So it's a single prolonged deceleration lasting for more than 3 minutes. So the guideline tells you, if you look at the CTG before the deceleration, if you have reduced variability before and reduced variability in the first 3 minutes, again this is based on scientific evidence, run, because most likely this is due to an irreversible cause. Whereas if you see here, again, reduced variability before, reduced variability in the first minute, run. And you can always come back, but run as soon as possible to the theatre because the likelihood of recovery is very, very low. Whereas the guideline tells you if you have normal variability before and the normal variability in the first 3 minutes, correct the problem. Often it's a uterine problem or sometimes maternal hypotension or sustained cord compression, which can be changed by changing the position. So again here, variability before normal, variability in the first 3 minutes normal, don't panic because they can see in the TOCO there's a problem. You correct and these have a high chance of recovery. And one of the things we have added in this guideline is chorioamnionitis. So we know that in chorioamnionitis you're going to have increase in the metabolic rate. So if it happens in the antenatal period, the fetus is going to come to you with higher than expected baseline for gestational age. If it happens during labor, your fetal baseline heart rate is going to increase by more than 10%. That's because 1 degree rise in temperature approximately increases the heart rate by 10%. And these fetuses, as this infection spreads, like us, when we have bad bacterial infection or viral infection, we don't want to move, we don't want to go to the gym. So they reduce the accelerations to conserve energy and depression of the somatic nervous system. They may not be able to go into deep sleep, just like you and I. When we have severe fever, we can't fall asleep unless we take paracetamol because there's excessive neuronal firing. So these fetuses will have normal variability, and this is why all guidelines sadly miss them. Because if you have normal variability throughout labor, that is equally bad. And then finally, end stage would be myocardial failure and cerebral failure, and you are going to have zigzag pattern, etc. So again, the reason we included this is that in the last few years, last 5 or 6 years, we have got lots of scientific evidence coming in. So Laetitia Gali was one of my clinical fellows when I was working at St. George's Hospital in London, and we looked at 2,105 cases, and we published the first paper on chorioamnionitis, what are the physiological or pathophysiological changes you see in the CTG. And with Suganya, who is my consultant colleague from the Midlands, we looked at histopathological cases of chorioamnionitis, and we were able to show what we showed with Laetitia's paper, that there are certain features of neuroinflammation and 10% rise in the baseline which are associated with chorioamnionitis. And then with Susanna, we were able to show absence of cycling is a very important feature that is associated with maternal pyrexia. And more recently, with Tullio Giesrup and Elvira as the first author, we were able to show that if you have features suggestive of fetal inflammation, or SOFI, we demonstrated a 4-fold increase in the levels of interleukin 6 in the umbilical arteries at the time of birth. So now, not only histologically we have proven, now biochemically, as we know, interleukin 6 is the marker of fetal inflammation. And if you find these features that we are talking in the guideline, you are going to, it has been shown to be associated with a 4-fold increase in interleukin 6. And this is the reason why we have said in the guideline, if there's a 10% rise in the baseline without preceding inflammation, deceleration, that is a sign of chorioamnionitis. If the variability remains normal, but there is no reduction in variability where the fetus is unable to go into deep sleep due to increased neuronal metabolism and neuronal firing, neuroinflammation. If you have zigzag pattern, you can see there is no repetitive decelerations, but zigzag pattern is happening in a higher than expected baseline. That is a sign of neuroinflammation. And the pool shark teeth pattern also is a sign of neuroinflammation. Finally, we also wanted to highlight some of the abnormal patterns, like typical sinusoidal pattern you get with chronic fetal anemia acidosis, pool shark teeth pattern you get with acute fetal-maternal hemorrhage, and you can see there's a mountain here, there's a mountain here, there's a mountain here, there's a mountain here. That is what we call a double mountain peak sign that usually we get in second stage of labor when we wrongly monitor the mother's heart rate as fetal heart rate. Because with contraction, if you're a fetus, your head gets compressed, your cord gets compressed, your placental blood supply gets cut off. Your natural physiological response is to protect the myocardial workload by reducing your heart rate. If you are a mother, you are big, it's painful, you are anxious, you have pain, and each contraction pumps a lot of blood from the uterine sinuses into your system, and that increases your blood volume and you increase the heart rate to compensate. So maternal heart rate increases with contractions, like a mountain, double mountain peak sign. And that is also an unusual pattern. So intrapartum hypoxic stress, gradually evolving hypoxia, subacute hypoxia, and acute hypoxia. And remember, these don't occur in boxes in all fetuses. And that's something we had to get away with. Because I could be in the gym, I'm starting my journey in the gym, in the treadmill. So I'm going to have gradually evolving hypoxia. But if you come and increase the speed, I go into subacute hypoxia, same me. So it doesn't happen in boxes. It can be a continuum. And if you don't stop the treadmill and if you push me, I have a myocardial hypoxia, arrest, and I fall. I have an acute hypoxia. So here you can see it's a gradually evolving hypoxia with a reduced variability, so decompensated. And then if you start the same movement to start pushing, it changes into subacute hypoxia, and if you're not careful, the same fetus goes into acute hypoxia. So please remember, these are not to be considered in isolation. They can happen in boxes, but often a fetus who is exposed to gradually evolving hypoxia and therefore has reduced reserves now, when you start pushing, and the same fetus can develop subacute hypoxia. And then if you're not stopping the pushing and increasing the oxygenation, that baby can crash. Whereas some fetuses would be entirely normal in the first stage of labor and de novo develop subacute hypoxia in second stage of labor. So these tools are there to help us, and we have also said that in the guideline, in the tool, that sometimes these can be combined. We need to really understand that. So hypoxic stress, please remember, two things we have to always consider: the intensity of the hypoxic stress and the duration of hypoxic stress. So as the intensity increases and the duration increases, obviously there's a risk of fetal hypoxia acidosis. But it need not happen that way. When there's a sudden abruption, cord prolapse, you may not have duration but high intensity. The fetuses, when they have low intensity and it is lasting for a shorter time, they are able to compensate. Then they are able to redistribute to protect the central organs, and they have buffering capacity too. But if you have a sudden intensity like abruption, cord prolapse, they may not have these defense mechanisms, and that's why in acute hypoxia, if you have reduced variability before the deceleration, prolonged deceleration, and reduced variability in the first 3 deceleration, we need to rush. So fetal, intrapartum fetal monitoring, it's a journey that we are monitoring, and CTG is just one part of the journey. So the questions we need to be asking at the beginning of labor: is this fetus fit for labor? So we are going to do part 2 of this presentation based on those tools. Evaluate the antepartum and intrapartum risk factors, because if the woman is coming with ruptured membranes, there is chorioamnionitis until proven otherwise. Otherwise, why would membranes rupture without pressure? And therefore that risk is going to operate during labor. Then you have type of hypoxic stress, type of ongoing stress. Is it hypoxic? Are there decelerations? Is it inflammatory, or is it something else? And assess, continuously assess whatever the types of decelerations are in the CTG. How are the fetal central organs? Do I continue to see stable baseline and reassuring variability? And finally, take an overall context. How is the stage of labor? How is she progressing? Because intrapartum care and intrapartum fetal monitoring involves all this. So once again, I would like to thank the editorial board for their hard work and their contribution to physiological interpretation of CTG. I'd like to thank each and every member of the International Consensus Panel from over 20 countries. And I want to emphasize that this is a consensus statement. It is not perfect. We didn't intend it to be perfect, because we have to appreciate that there are lots of us in different stages on this journey. Those who did fetal blood sampling earlier, they are not doing fetal blood sampling now. Why? They understood it. Those who gave fluids for chorioamnionitis, for suspicious CTGs, they are not giving fluids any longer to the mother. Why? Because they understand physiology. So they may be on this side, but with further evidence, I hope we keep moving the goalposts. So if you see our guideline, we didn't make it perfect. That's not the intention. It's a journey in progress. So you may not agree with whatever that is stated in the guideline, but remember, we had to agree 15 members of professional people, midwives and doctors of various grades, we have to agree. 50 members from 20 countries with different cultural practices, obstetric practices, we have to agree. So we are so pleased that we were able to agree. And if some of these aspects of the guideline are not in agreement with you personally, I do apologize for that on behalf of the entire editorial board and the consensus panel. But let's start this journey. And the guideline has evolved from 2018 to 2024. I hope with further information and scientific evidence coming, we will keep updating the guideline. And I would like you to enjoy using it, and our common aim is to improve the outcome for women and babies. So thank you very much.